My name is Amr Mohamed. I'm a pediatric ophthalmology and strabismus consultant in Noor Yemen Eye Center, and also assistant professor of ophthalmology, Faculty of Medicine, 21st September University. Today, I will speak about what I wish I knew for my first 100 strabismus surgeries. There are no financial disclosures and photo consent taken from all patients. So firstly, starting with the objectives of this webinar, I will take you through a journey starting with the preoperative evaluation of the patient with strabismus, going through the intraoperative tips and tricks to make your surgery smoother, and I will show some videos about the strabismus surgery steps, and finally, postoperative care and management of complications and the postoperative surprises that I know that everyone who is doing strabismus surgery will have some of these surprises. Also, I will speak briefly about resurgeries. So starting with the poll questions, where are you in training? Are you a junior resident, senior resident, general ophthalmologist, pediatric ophthalmology fellow, pediatric ophthalmologist, or allied health professional, optometrist, or ophthalmic nurse? So we have 5 poll questions. In those 5 questions, I will try to understand the audience. So perfect. We have 31% pediatric ophthalmologist, 28% general ophthalmologist, and 19% allied health professionals, optometrists, and ophthalmic nurses. Great. Let's go to the second question. How many strabismus surgeries you have done? None, or 1 to 50 surgeries, 50 to 100, or more than 100 surgeries? Okay. So the majority haven't done strabismus surgery, 40%, with 19% 1 to 50 and 50 to 100, and 22% more than 100 surgeries. Great. Let's go to the third question. How do you measure strabismus deviations? Would you do Hirschberg test or Kremesky method or alternate prism cover test, APCT? So what is the method of measuring strabismus deviation that you usually use in most of your cases prior to surgery? Okay, great. I'm happy to see these results. We have almost 2/3 are doing APCT, and that is so good. Let's go to the third question. The fourth question, sorry. What is your preferred technique for routine strabismus surgeries? Would you prefer to do limbal incision or fornix incision or other incisions like Swain or minimal incision? Okay, so 54% limbal, 30% fornix, and 17% other incisions. Great. Coming to the last question, what do you use in strabismus surgery? Do you use surgical loops or operating microscope, or you don't use either in your surgeries? Okay, so 26% are using surgical loops, and almost 50% are using microscope, and 25% are not using. Okay, so let's go through the presentation. I will start with a small introduction. So my journey started in medical college as I wanted to be a pediatrician and ophthalmologist. And to combine those two specialties, I chose to pursue pediatric ophthalmology and strabismus from the first day of my ophthalmology residency. After completing my ophtha residency, I got a position at Shankar Eye Hospital to pursue 2-year pediatric ophthalmology fellowship. And the good thing about the fellowship and about the training that during your fellowship, you're undercover, you feel that your mentors will have your back. They can help you in tailoring your management plan. Any intraoperative surprises, they will help you through. But after fellowship, I was feeling lost. No senior person, complicated cases referred to me what to do. In a country of 35 to 40 million population, no fellowship certified pedophthalm at that time. I put my ego aside and I realized that fellowship is just the beginning of the journey. So I continue contacting my mentors at Shankar Eye Hospital, and they helped me a lot post fellowship. I used to ask them about the difficult cases, and they used to help me a lot. Also, Cybersite Consult, and this is a free service for the low and middle income service resources countries. You can ask and put your consultation, and you'll get the answer within 24 to 48 hours. Also, learning from my cases, calling the patient for follow ups, and understand what is happening for the patient post-operatively. So that will help you a lot in tailoring your numbers and also will help you a lot in taking the decision to take the patient to operation theater. Also, I would recommend to read a lot, check the related articles, textbooks that are related to your cases, read about the techniques, the outcomes, the complications, and watching surgical videos, especially the day before your operation theater. That is a very important point because when you saw the procedure again and again, you will develop a muscle memory and you will visualize the procedure. When you will do the procedure, you will feel like you are familiar with this procedure. You will feel like this is not the first time you are doing that surgery. So watching surgical videos is of extreme importance. And at the end of the webinar, I will help you and tell you about many resources where to watch surgical videos. Let's go to the first part of the webinar, the preoperative evaluation. So tip number one, basic tips I will start with, then we will go further with the more advanced tips. Proper history taking. And this is a great quote. There is no substitute to good history obtained at the start of the examination. So you should take a proper history taking from each strabismus patient. That will help you a lot in understand what the patient is having, what is the diagnosis, how to deal with the patient, starting with the personal history, history of neurological and developmental disorders, history about the deviation, diplopia, past ophthalmic history, and family history of squint, refractive error, or amblyopia. Tip number two, evaluation of visual acuity as a start point. That will help you in deciding what is the best way to measure strabismus angle. So generally speaking, if the best corrected visual acuity is 636 or better, you can do alternate prism cover test. But if the vision is less than 636, 660 or less, then you have Kremsky test to do. Regarding Kremsky test, it's very easy. So in such patient with esotropia, I will put the prism base out in front of the fixating eye, and I will increase the prism power until the reflex in the deviated eye became central. And this is the angle of deviation. This is an example of patient with right hypotropia and vision of hand movement in the right eye. So I put a base down prism over the fixating eye till I correct the whole hypotropia in this patient. Tip number three, a lot of data you can get without touching your patient. And this is especially important in pediatric patients. So from inspection, you can figure out if there are any dysmorphic features like Down syndrome, Crouzon syndrome, facial asymmetry like patient with plagiocephaly or hemifacial atrophy in congenital fourth nerve palsy, or abnormal head posture, whether patient is having head tilt, face turn, or chin elevation or chin depression, and the visual behavior of the patient that will help you. So for example, this patient is having left head tilt. This patient is having chin elevation. Tip number four, it's always better to start with your sensory evaluation. And it's important to understand what is the sensory status of your patient. That will help you a lot in tailoring your management plan, and you will get to know whether you need to undercorrect, overcorrect, or to plan for orthotropia in this patient. And for sensory evaluation, I usually use Warford test. It's a very helpful and very simple test. Striated glasses, and of course, for stereopsis. Tip number 5, never use a light as a fixation target. It's a very simple advice, but it's also extremely important because I saw many colleagues who are using light as a fixation target, and you should always use an accommodative target with details. These are some of the targets that I'm using in my clinic. So we have the ruler with shapes, letters, numbers, and drawing for the children. So during the alternate prism cover test at near, you need to make the patient focusing on the target and ask him questions about the target, so he will be attentive through the examination. Tip number 6, always measure the angle in different gazes at distance. So in patient with horizontal deviation, you need to have the angle of deviation in the primary position and in up gaze and down gaze to elicit if there is any pattern, V pattern, A pattern. Also side gazes, right and left gaze, that will help you to elicit if there are any lateral incompetence. In patient with vertical deviation, you need also to add measuring the angle in head tilt, right and left head tilt, the third step, to isolate which cyclovertical muscle is affected. Let's take this example. This is a patient with 70 prism diopter exotropia. In up gaze, the exotropia increases to 110 prism diopter. In down gaze, it decreases to 45 prism diopter. So we are having a large V pattern exotropia. In right gaze, the angle is 65. In left gaze, the angle is 60. So the patient is having small lateral incompetence. But if you have a patient with 70 prism diopter in primary position and, for example, 50 prism diopter of exotropia in side gazes, you need to decrease the number that you will correct so the patient will not develop diplopia in side gazes. Tip number 7, always draw your diagram of extraocular motility and take your time in eliciting overactions and underactions. So we have 3 ways to draw the extraocular motility, whether to have this circle or H or this X shape. So for example, let's take this shape. This is the diagram for the right eye. So the patient is having +2 inferior oblique overaction, -1 superior oblique underaction, and abduction is normal. In the left eye, patient is having normal adduction and -4 limitation of abduction. Drawing your diagram in your notes, and that will help you a lot in the subsequent follow-ups of the patient to understand whether there is any worsening or improvement in the extraocular motility. Take this example. So what are the findings here and here? So here we are having +4 inferior oblique overaction in both eyes and around -2 superior oblique underaction in both eyes. Tip number 8, do not start your examination with presumed diagnosis in your head. And this is a common mistake that many of us will do. So when you are having a patient with right head tilt, for example, and hyperdeviation, you will assume that the patient is having left SO palsy. But in strabismus cases, do not start your examination with any presumed diagnosis. Take the examination and the history taking step by step and join all the puzzle pieces to reach the proper diagnosis. Tip number 9, there are many things that can cause errors in the measurement, like eccentric fixation in patient with deep amblyopia, patient who are wearing high plus and minus glasses, because glasses will have a prismatic effect. So I usually, if the patient is wearing anything beyond -4 or +4 diopter lenses, I will prefer to do the measurement when the patient is using contact lenses. Remember, if the patient, for example, is wearing -10 diopter glasses, and you got, for example, 30 prism diopter of exotropia, this is an overestimation to the angle of the patient. If you repeat the measurement with the patient wearing contact lenses, you can find it maybe 20 to 25 prism diopter of exotropia. And in the plus lenses, the opposite. So if the patient is wearing +10 diopter glasses and he's having, for example, 30 prism diopter of esotropia, so usually with glasses, the angle of deviation is less. Also, make sure that your patient is fixating and attentive through the alternate prism cover test. If patient is not fixating or attentive, you will not get a proper measurements. Patient with large angle squint, you need to ask them to read slowly because of the large prism you are putting in front of the eyes. Patient will need more time to fixate on the target. So you need to do your cover test slowly and shifting your hand slowly after making sure that the patient is fixing with the uncovered eye. Tip number 10, repeat, repeat, repeat. So patients required, especially with small children, you need to take your time in examining the patient. You can call the patient for second or third visit to re-evaluate and repeat your measurements. And I would advise everyone to have at least 2 proper complete measurements before taking the patient to operation theater. That's extremely important. You will be surprised with the variability that can happen in strabismus patients. So you need to repeat your measurements to make sure that you are having stable numbers before taking the patient to operation theater. Tip number 11, take a consultation from a senior colleague. Always consult even basic and simple cases in the beginning. Better to take opinions of multiple mentors or seniors. But remember, you are the one who is responsible for the patient, who you are the one who have the complete picture. So you will have to decide at the end. One more important thing that, for example, esotropia cases are not all the same. For example, this nomogram is using only for infantile esotropia. So usually for infantile esotropia, we tend to use lesser numbers than patient with other types of esotropia like partially accommodative esotropia or acute acquired comitant esotropia or sensory esotropia. Also, some studies suggest to take the measurement from the limbus when we are doing medial rectus recession. So for example, this table, if the patient is having 40 prism diopter of esotropia and you are planning to do bilateral medial rectus recession, if the patient is less than 1 year, you will do recession 10 millimeter from the limbus, that is around 4.5 millimeter. And if the patient is above 1 year, you will do 10.5 millimeter from the limbus. That means it's around 5 millimeter recession. Why we are taking the measurement from the limbus? Because many studies shown that in infantile esotropia cases, sometimes there is a variation in medial rectus insertion. These are nomograms for other types of ET, as I mentioned. This is from Dr. Kenneth Wright. This is from Narayana Netralaya Hospital. And you'll find differences in the numbers, maybe around 1 millimeter or 0.5 millimeter from one nomogram to the other. Also, this is for exotropia. This is again for exotropia surgery from Dr. Rosenbaum textbook. So the point is, adopt one nomogram, do your cases, and check your patient postoperatively. Then you will get to know whether you need to increase the numbers or decrease the numbers accordingly. Tip number 13, patient with same diagnosis and same strabismus angle may have different post-operative results. Many other factors contribute to the post-op results other than angle equal dose. And that's a very important thing because I got many questions from my colleagues. Dr. Amr, please, I have a patient with 30 prism diopter, esotropia. How much should I do? That's not enough to decide how much you need to do, for example, bilateral medial rectus recession. There are many factors contribute, like if the patient is having amblyopia or no, if the patient is having fusion or no, if the patient is having A or V pattern, any vertical deviation, if the patient is having latent nystagmus, DVD, if intraoperatively, when you do the force reduction test, you find tight muscles. So, for example, if I'm planning to do a bilateral medial rectus recession of 5 millimeter for the patient, but intraoperatively, I found force reduction test positive +1 or +2 tightness, then I would reduce my numbers. I would reduce my numbers maybe 0.5 millimeter up to 1 millimeter from the numbers that I planned preoperatively. Also, presence or absence of refractive error, presence of absence or absence of neurological problems, especially in small children with cerebral palsy. In those patients, usually we tend to undercorrect, and usually the results are unpredictable in such patient, and the success rate is much lower than patient with no neurological problems. Coming to tip number 14, always remember for basic esotropia, always aim for smaller angle measured. When I'm saying basic esotropia, I mean the difference between the angle of deviation at near and at distance is within 10 prism diopter. So for example, if the patient is having esotropia at near 60 prism diopter and esotropia at distance 50 prism diopter, I will definitely go for 50 prism diopter correction. I would prefer to have esophoria at near 10 prism diopter postoperatively rather than do overcorrection and having 10 prism diopter exo postoperatively. Remember that ET patients tend to go for consecutive exotropia even with the slightest overcorrection. Tip number 15, always remember in basic exotropia, always aim for the largest angle measure. That is exactly the opposite. So for example, if the patient is having exotropia 50 prism diopter at near and 60 prism diopter at distance, I will go for 60 prism diopter, especially if the patient is having good vision in both eyes. So exotropia patient tend to have recurrences. Aim for slight esotropia postoperatively, 5 to 10 prism diopter. That will give better long-term results, but counsel the patient about possible transient postoperative diplopia. And this is tip number 16 about post-op diplopia test that I would recommend everyone to do it for all the patients with good vision in both eyes. You put the prism and check if the patient is experiencing any diplopia or not. If there is no diplopia preoperatively, then you are safe. But if the patient experienced diplopia preoperatively, you need to counsel the patient that there is a possibility to have a diplopia postoperatively, and this diplopia might remain for a few weeks. In my personal experience, I found patients with esotropia and abnormal retinal correspondence. Sometimes diplopia may persist for longer periods. Tip number 17, adopt adjustable suture technique. It's a great technique and it's very useful in selected cases. So in my experience, I usually use adjustable suture technique in paralytic strabismus cases, 3 or 4 muscle surgeries, especially exotropia and thyroid eye disease. If it is not possible to do adjustable sutures, if you are doing any of those patients with unpredictable results, you need to counsel the patient that you might need second stage surgery to titrate the results. I will go through 2 examples of a patients that I did for them adjustable sutures. This is a young patient, 22-year-old male with acute acquired comitant esotropia and diplopia. He had 30 prism diopter esotropia. So I plan to do bilateral medial rectus recession of 5 millimeters, but I put the medial rectus recession in the right eye under adjustable sutures. Postoperatively, I checked the patient. He still had diplopia and residual esotropia. So I increased the recession in the right eye to 6.5 millimeters. So the patient is orthotropic and diplopia free. This is another example of elderly female patient with thyroid ophthalmopathy and large angle esotropia. I did bilateral medial rectus recession under adjustable sutures, and now patient is orthotropic with no diplopia. So adjustable suture technique is extremely important in such cases, especially patients with diplopia. Tip number 18, take your time to analyze the case. Do not jump to diagnosis. Remember, strabismus is just like puzzle. So you need to align, assort the pieces patiently, starting with proper history taking, inspection, examination, investigation if needed, repeating all the steps, elucidate any missing pieces. Only then you can get the complete picture and you will reach the proper diagnosis and proper management plan. Do not rush to surgery, especially in small kids. Treat those patients in a systematic way. Always start with correct any significant refractive error. Treat amblyopia as much as you can. Then only take the patient to operation theater. Tip number 20, and the last tip in the preoperative evaluation, counsel the patient about the post-op complications and course. Your expectations must meet patients' expectations. Some patient will have unrealistic expectations. You need to tell them exactly what you can do and what you cannot do. I will give you some examples. For example, patient with partially accommodative esotropia. I need to tell the family that the patient will be straight eyes when he is wearing the glasses, but when the patient remove the glasses, he will have esotropia. Same thing with Duane retraction syndrome, patient with DRS type 1, severe globe retraction, limitation of abduction, face turn, esotropia in primary position. I am planning to do medial rectus recession for the patient. So I will tell the patient that I can treat the primary position esotropia. Face turn will improve, but abduction limitation will not improve, and globe retraction might persist. Excuse me. Also counsel the patient about the success rate and need for second surgery. Myself, I usually tell the patient with straightforward cases, 70 to 80% success rate. In patient with paralytic, restrictive, or resurgeries, I usually give them 50 to 60% chance to have a perfect alignment after the first surgery. Counsel about importance of continuing on amblyopia therapy and glasses if needed. Going to the second part, intraoperative tips and tricks. First and foremost, you need to know your anatomy before touching your patient. You need to know the anatomy of the extraocular muscles by heart. You need to know the places of the vortex vein so you will get to avoid them during the surgery. If you hit vortex vein, you will end up with severe bleeding, and that will make your surgery very difficult. So you need to know the anatomic insertion of the recti and the obliques, where to find the obliques, what is the tendon length, what is the arc of contact, what is the action of each muscle. That is of extreme importance. Also to know about the tenon capsule, the anterior tenon, posterior tenon. Also, you need to know about your instruments. For example, here we have the cautery, we have the caliper, the artery, the small hooks, the large hooks, the DMAR. We have the needle holders and the toothed forceps and Moody locked forceps. That is extremely important and useful. Also, whisket scissors and speculum. In some cases, you might need more instruments like, for example, Kenneth Wright grooved hook for patient with tight muscles. It's very helpful. You need also to know your sutures. So for securing the muscles, usually we use Vicryl 60 spatulated needle, side cutting needle. You should not use any other needles in securing the muscle. If you use round needle, you will end up with scleral perforation. So make sure that you read on the suture that it is 60 Vicryl and spatulated needle, side cutting needle. For transposition surgery, so with Foster sutures, modified Nishida chicken sutures, where I need non-absorbable sutures, usually I use 50 polyester suture. For conjunctival closure, I use 80 Vicryl sutures. For anesthesia, it's always preferable to start doing your strabismus surgery under general anesthesia. After 30 or 50 cases, you can select some adult patients and do the surgery under local anesthesia, but you need to make sure that the patient will not feel a lot of discomfort during the surgery. You can check this by touching the conjunctiva in the clinic after putting topical anesthesia and see if the patient is cooperating or not. One more important thing is the oculocardiac reflex that happened a lot during strabismus surgery and bradycardia. So you need to have alert anesthetist and you need to have all the facilities, the CPR cart in the operation theater room. You need alert anesthetist to observe the monitor throughout the surgery, especially during muscle hooking. If oculocardiac reflex triggered and the patient starting to have bradycardia, you need to immediately remove the hook and wait. If still patient is having bradycardia, then the anesthetist will give the patient IV atropine. Using tropicamide or phenylephrine eye drops is very important. It will cause conjunctival blanching and it will minimize bleeding. Or using brimonidine eye drops, but remember to use brimonidine only in patients above the age of 5 years. Using operating microscope, I would recommend for your first cases to use operating microscope. I myself had the opportunity to operate with surgical loops during my residency, and during fellowship, I operate using microscope, and now I'm using only microscope. And believe me, operating microscope will give you more fine details. It will give you more stability, and you will be more comfortable during the surgery, uh, especially in complicated cases, resurgery cases. It is more helpful than loops. Positioning of the patient. Remember, always patient should be extended so you will have good exposure of the eyes with drape to remove all the lashes from the surgical field. And always do force duction test at the beginning of all cases. Let's see these two videos. So this is a patient with comitant esotropia. Here, if DT is negative, you can see the eye is moving freely. What about the other case here? Lateral rectus is okay, but medial rectus is extremely tight. That is a patient with Duane retraction syndrome. You can see medial rectus is very tight. Regarding the incisions, limbal versus fornix incisions, I would recommend to start with limbal incision for all your recti muscle cases. It is much easier. It will give you better exposure, and hooking and isolating the muscle will be much easier. And fornix incision can be used for oblique muscle surgery. Let's see this patient with limbal incision. So this is a patient that will have medial rectus surgery. You can just do 3 clock hours opening. That will be more than enough to have better exposure. For fornix incision, this is a patient that I will do for him inferior oblique recession. So inferotemporal quadrant, I measured 8 millimeter from the limbus and starting with small conjunctival opening, then holding the tenon with 2 toothed forceps and asking the assistant to cut between them till you can see the bare sclera. Then only you start hooking the muscle. Here is holding the tenon up and starting cutting in between till you reach bare sclera. Yes. Here you can see we reach the sclera. Then here is the inferior oblique muscle. Starting with a small hook against the sclera. Then hooking and isolating the muscle. You need to, after doing the limbal incision, you need to have a good scleral pocket, putting the hook posteriorly and perpendicular to the sclera, and you will get the whole muscle. After hooking the muscle, you will start cleaning the tenon. Remember always, you need only to clean extensively at the part that you will put your sutures. So for example, if you are doing recession like this case, I will focus on cleaning the tenons in the insertion of the muscle where I will put my sutures. But if I am doing resection, then you need to clean the intermuscular septum and the tenon till the point where you will put your sutures. The thing that you don't want to have tenon with the sutures, so that will minimize the risk of having muscle slippage. After cleaning, we will start usually with partial thickness suture, then full thickness suture. I usually take 1 partial thickness and 2 full thickness sutures. On each side. So here is the half of the muscle. Now I am taking partial thickness suture, then full thickness suture with locking bite, Again, I will take another full thickness suture at another point to make sure that I am securing the muscle perfectly. After securing the muscle, holding the hook and the sutures and disinserting the muscle from the sclera. After that, securing the muscle, you need to repeat caliper measurement and make sure of your measurements. During the scleral pass, you need to have a stable hand, tip of the needle always pointed upward, and pushing the needle slowly while fixing the globe with tooth forceps with the other hand. And remember, you should always see the shadow of your needle throughout the surgery. So here, after this inserting the muscle, I will measure 6 millimeter from the muscle insertion. So usually you should hold the needle halfway and go slowly with the tip pointed upward to avoid having scleral perforation. Again, cleaning the field and making sure of the measurements. You should have dry field so you can do your scleral pass comfortably and without any problems. Pointing the needle upward slowly till you come out with the needle. After that, you should put saline on the vicryl suture. Remember, vicryl is easy to cut, so you need to put saline while tying the sutures so the suture will not cut. You need to make sure that the muscle reaching the exact point where you put your sutures. I usually do 2, 1, 1, 1 to secure the muscle. The first one is usually the most important. The other one is to just confirm. So 2, 1, 1, 1 is enough. And leaving 1 millimeter of the suture at the end. Of course, bleeding happened in strabismus surgery. Don't panic. Most of the bleeding is self-limited and it will stop only by compressing with the swab for a few seconds. If it is bothersome, then you can use cauterization. Coming to the last step of the surgery, the conjunctival closure. Take care of conjunctival closure. Do it neatly. Avoid getting tendons on your sutures and trim tendons. Also trim conjunctiva after suturing if it is covering cornea to avoid foreign body sensation and dull information and patient discomfort. So here we can see conjunctival closure using 8-0 vicryl suture. Start with the limbal suture. 2-1 is enough usually, or 2-1-1. Then doing the other sutures. Always remember to take only conjunctiva. Avoid taking tenon to conjunctiva. If you are having tenon outside, you will have a higher rate of tenon cyst, tenon or granulomas. So remember to close only conjunctiva with conjunctiva. That will have better cosmetic results and better functional results. Coming to the last part, post-operative care. So post-op regimen and follow-up visits. Usually post-op medications, I usually give antibiotic steroid eye drops, QID, with lubricant eye drops or gel. It's of extreme importance because remember, you are doing ocular surface surgery. So definitely patient will experience foreign body sensation and dryness. So you need to give the patient lubricant eye drops for at least 1 or 2 months post-operatively. Follow-up visits, post-op day one, you need to check ductions to make sure there is no muscle slippage, the alignment, conjunctival sutures, any signs of infection or severe reaction. Then usually I see the patient post-operative 2 weeks, 1 month, 2 months, and post-operative 6 months. Coming to post-operative surprises. Many times post-operative results will be surprising. Sometimes you will get undercorrections, sometimes you will get overcorrections, sometimes you have stable results throughout follow-up visits. Many factors contributing. Give it time. In most cases, you will get more stable results after 6 to 8 weeks of the surgery. So don't panic. For example, in a patient with esotropia and post-operative day one, you still having residual esotropia, don't panic. A patient will have better alignment with time. Usually 6 to 8 weeks, you will reach more stable alignment. Follow your patient thoroughly. For example, this is a small child with infantile esotropia. I did for him bilateral medial rectus recession 4 millimeter. Post-operative 2 weeks, he had a residual ET of 16 prism diopter. But, but post-operative 6 months, that came down to only 6 prism diopter of esophoria. This is also a case of a large angle esotropia in the right eye. The patient had 90 to 200 prism diopter of esotropia. I did for him medial rectus recession with lateral rectus resection and true muscle transplantation. Post-operative day one, I was frustrated because the patient had almost 30 prism diopter of residual esotropia, but with time, on post-operative 4 months, patient came with perfect alignment. This is a patient with consecutive exotropia and bilateral DVD. So I did for the patient bilateral medial rectus advancement with inferior oblique anterior transposition. Post-operative day one, patient had consecutive esotropia around 20 prism diopter, but with time, patient became orthotropic and she is still maintaining orthotropia after 1.5 years post-surgery. So in cases of undercorrection or overcorrection, you can always use refractive error to your side. You can use the refractive error to help you improve the results. I will give you 2 examples about that. If you are having patient with esotropia and you happen to have overcorrection, small exotropia post-operatively, and the patient is wearing +5 diopter glasses, that is the full cycloplegic refraction of the patient. So you can easily cut half the amount of the plus, putting in mind not to compromise the vision. When you reduce the plus lenses, definitely you will help the patient to having a better alignment. Also, if you are having patient with exotropia and post-operatively the patient had consecutive esotropia and he is wearing 3+3 diopter glasses, when you did for him cycloplegic refraction, you found +7 diopters. So you can add more plus to reduce the consecutive ET angle for this patient and to have better alignment. Remember, your patients are your teachers. It's very common to face many difficulties in your first cases. Post-operative surprises, unexpected post-op results, wrong decisions, and a lot of surprises can happen. Be prepared by good communication with your patients, proper counseling pre and post-operative. You should give the patient realistic expectations. You should tell the patient about the expected success rate and the percentage of the need for second surgery for the patient. Call your patient for follow-up visits to understand what is happening with the long-term follow-up and you can always take your patient back to operation theater to do second, third, or fourth surgery to get the best results. Remember, this is one of the privileges of strabismus cases that might not be found in other subspecialties of ophthalmology. Lastly, 3 slides about resurgeries. In resurgery, tips that can help you through the journey of diagnosis and management. Take proper history, which I operated, any reports, any pictures pre and post the first surgery. Check motility, any limitations, widening of the palpebral fissure, lateral gaze incompetence, conjunctival scarring. All these signs will help you a lot in understanding which muscle operated. Is there any muscle slippage? Is there any stretched scars? And you should always have at least 2 plans before taking patient to operation theater. For example, patient with consecutive exotropia and limitation of adduction, you should have in your mind 2 scenarios. If medial rectus found, then you can do medial rectus advancement. But if you cannot find it, then you should do partial vertical rectus transposition to help in correcting the exotropia and to help in having more adduction. In resurgeries, be prepared for longer operation time, more adhesions, bleeding, prepare your cautery, good assistant, and good instruments. That is one of the debates in resurgery, whether to work in previously operated muscles or fresh, untouched muscles. It depends whether there is any limitation of ductions, then you should go back to the previously operated muscles. But if there is no limitation of ductions, you can go for the fresh, untouched muscles. Sometimes you leave the untouched muscles for another surgery if you need in the future, and you can work again on the previously operated muscle. Also, this is a question, is there any difference in the surgical dosage? In resurgery cases, definitely there is a difference, but unfortunately, there is no nomograms for resurgeries. But remember, for example, in a patient with esotropia who underwent bilateral medial rectus resection before, and you are planning to do lateral rectus resection for the patient, remember that it will be more powerful than normal because you are doing LR resection in an eye with already weakened medial rectus before. And it's always better to use adjustable suture technique in resurgery. At the end of the day, it is a rewarding subspecialty. Seeing your patients with increased confidence and self-esteem, restore stereopsis, alleviate diplopia, watching your patients perfectly aligned with a huge smile, it is worth it. Thank you so much for your attention. And these are some resources that will help you through your strabismus surgery journey. There are courses on CyberSite for pediatric ophthalmology and strabismus, surgical videos in CyberSite library and YouTube. There is a complete course, strabismus and amblyopia, free comprehensive video course, and this is the link. Also, textbooks like Clinical Strabismus Management by Dr. Arthur Rosenbaum and Binocular Vision and Ocular Motility by Dr. von Norden. Thank you so much. And now I'm ready to take your questions. Okay. So we have one question. Maximum medial rectus LR recession that you perform with competent cases of ESO and EXO. So usually for medial rectus recession, I do not go beyond 6 or 6.5 millimeters. Okay, if you have very large angle, then you can easily do 3 muscle surgery. For LR recession, you can go for 9.5 up to 10 millimeter of lateral rectus recession. My experience with PAT, I don't do prism adaptation test. Unfortunately, we don't have Fresnel prism in my country. Which one you use or C is more accurate, APCT or APCT is the gold standard for strabismus evaluation. Okay. Do you use microscope? Yes, I use microscope for all my strabismus cases. As I mentioned before, it is very helpful. You will have all the fine details. You will see the vortex vein. You will see the small vessels. So you will have better and neat surgery. Do you do prism adaptation test in children? No, I don't do it. Uh, can you please tell which adjustable suture technique is good for beginners? I usually use bow tie technique. It is very easy, very helpful. Bow tie technique is very simple technique. We have other techniques, but I usually use bow tie technique. Can you explain how do you do post-op diplopia test? So, for example, you are having patient with 40 prism diopter exotropia. So you will put the prism over one of the eyes and you will ask the patient, can you see one image? Do you see one image or two image at distance and at near? So if the patient is seeing one image, so post-op diplopia test is negative. If the patient is seeing two images, so that is positive. And if it is positive, you need to uh, counsel the patient about postoperative diplopia. How do you set the target for partial accommodative esotropia? What is the best timing to do the surgery? The best timing is when you are having stable alignment and you treat the amblyopia as much as you can and you repeat your cycloplegic refraction at least twice. So you are sure about the refractive error, you are sure about the angle of deviation, and you treat the amblyopia. Then you can proceed with the surgery. The target, as other esotropia cases, I usually prefer to have the patient with 5 to 8 prism diopter of undercorrection of esophoria. That will be more stable than other results or other target. Do you use prism cover test in 5 position of gaze with or without glasses? It is most importantly to do it with the glasses. You can do without glasses in cases of accommodative esotropia to understand what is the difference. But usually I do the alternate prism cover test with glasses for all the gazes. If I have patient with inferior oblique overaction +1, I try to operate on it, but it was thickened and can't operate on it after 2 weeks. There is limited elevation. What I can do? Okay. So if you are starting having limited elevation, you might have intraoperatively fat prolapse, and that led to something called fat adherence syndrome. I would prefer to refer your patient to more senior colleague who can deal with such cases, because fat adherence syndrome is one of the complicated cases. Is the prism cover test done with both glasses and without glasses? As I mentioned before, the important thing is to do it with glasses. I do it without glasses only in patient with accommodative esotropia to understand how much the deviation with and without glasses. But you need at the end to do it with glasses. That is the more important that you will use in your surgery plan. I'm sorry, I can't answer this question. It is in Spanish. Can you show a resection video I'm sorry, I'm not ready for this now, but maybe in next webinars, I would love to do that. Do you use botulinum toxin? Yes, I use botulinum toxin in some cases, acute sixth nerve palsy. Sometime I augment media rectus recession with botulinum toxin in some cases. How do you plan surgery in partially accommodative esotropia? I think I already answered this question. How can we measure the deviation more than 50 50 diopters? 50 prism diopters. Usually, you will put the prism over two eyes. So you can split the measurement over two eyes. In my Strabismus, in my prism set, I have 50 and 45 prism diopters, so I can measure up to 95 prism diopter, putting one prism over each eye, so you can measure larger angle than 50 prism diopter. Can you comment on vessel preserving muscle detachment? Vessel sparing surgery can be done, especially if you are planning to do more than two recti muscle surgery on the same eye. But in routine cases with recession resection, two recti muscles, you don't need to do it. What is the youngest age to do strabismus surgery safely? Usually for infantile esotropia surgery, those are the youngest ones that I usually do surgery on them. I usually do it at the first birthday when the patient is 1 year and 1 month, making sure that I repeated cycloplegic refraction 2 times. I made sure there is no significant refractive errors, and I treat amblyopia properly. The patient is having alternate fixation and stable angle of deviation. Then only I take the patient to the operation theater. Optimal age, it depends on the type of deviation and the magnitude and the presence or absence of amblyopia. What is your opinion about hangback recession? I myself don't do hangback recessions. Only I do it in adjustable suture techniques. Otherwise, I don't do hangback. I do scleral pass because, as Dr. Munira mentioned, creeping can happen later on, and you will never know where is the muscle exactly. So I usually prefer scleral pass, scleral fixation. I only do hangback recession in adjustable sutures. Is the patient, if the patient had adherence syndrome, can benefit from steroid? Um, Steroid alone will not be helpful. You need to relieve any adhesions, and you can use triamcinolone injection intraoperatively to avoid recurrence of the adhesions. Do you find it better to measure deviation by putting prism in front of dominant or non-dominant eye? See, you have two types of deviation. If the patient is having comitant deviation, then there is no difference. Primary and secondary angle of deviation are equal. But if the patient is having incomitant strabismus, then you need to put the prism over the deviated eye because you need to measure the primary angle of deviation. Okay, how to measure more than 100? I usually measure up to 100. After that, you just will have an estimate, and in such cases, you need to counsel the patient that he might need second stage surgery, and definitely it's preferable to do such cases with very large angle to do them under adjustable suture. Young patient, 6-year-old with intermittent XT, 66OU with minus 0.25 diopter. Should we prescribe glasses? Actually, it's not very important. 0.25 diopter will not help a lot. So I might not prescribe it unless I am not planning to do the surgery now and the patient is still have good or fair control, then I can give the glasses to help the patient to stimulate the convergence and having better alignment. What is the maximal deviation we can correct with two muscle? When to consider doing three muscle instead of two muscle between 50 and 60? Okay. So for esotropia, I usually, in infantile cases, I do two muscle only, bilateral medial rectus recession, 6 millimeters or 6.5 millimeter, up to 55 prism diopter. Three muscle, I usually do only if I'm having 70 or 80 prism diopter of deviation. Then I know that I need third muscle to correct the whole deviation. In exotropia, usually up to 45 prism diopter, you can correct with two muscle, but anything beyond 45 prism diopter, you need three muscle. So for example, for 50 prism diopter of exotropia, I usually do bilateral LR recession 7 millimeter with MR resection in one eye, maybe 5 or 6 millimeters. What would your surgical dosage decision be if there is large difference between appearance and measured prism alternate cover test? Then you might have uh, other factors, whether angle kappa, whether telecanthus. Some patient will have the appearance epicanthic folds that will give pseudo esotropia appearance, telecanthus that will give the appearance of pseudo exotropia. But at the end, you need to trust the alternate prism cover test, and I will do the surgery according to prism alternate cover test. But I might counsel the patient about the appearance. How do you treat and when you operate on postoperative cyst and granulomas? I usually give those patients steroid with antibiotic combination for at least 1 to 2 months and see if it is improving or not. If it is not improving, then you should take the patient to operation theater and remove the cyst or the granuloma. Do you prefer muscle resection or plication? In most of my cases, I do plication right now. Sometimes I do resections, especially if I'm doing transposition, vertical transposition or something, but I prefer plication. And I hope that I will have the opportunity to present another webinar where I will show more about the other strabismus surgery techniques. Brown syndrome with 5 diopter of hypotropia with little chin elevation. Would you operate? So it depends whether it is congenital or acquired, whether the patient is having severe downshoot or not. And the age of the patient will play a huge role. If the patient is less than 5 years, I can wait. If the patient is above 5 years and he's having chin elevation with downshoot and hypotropia in the primary position, I would do the surgery for the patient. So thank you so much.